Welcome to Billings Clinic Health Magazine. I'm Leslie Blair, and joining me today are two Mohs surgeons. What's a Mohs surgeon, you wonder? Well, stay tuned. We're going to talk to Dr. Mark Jones, who's the Department Chair of Dermatology, and Dr. Jared Lund, who is a dermatologist, and both are Mohs surgeon. Welcome, fellas.
Thank you.
Thank you, Leslie. Good to be here.
Great. Let's start off with just your general training to be a dermatologist, and maybe what interested you in going into care for the skin.
Well, Leslie, I started in dermatology, chose it in medical school because it was fun. You know, we get exposure to a lot of different things going through medical school, and I got to dermatology and I was like, this is it, this is fun. So I did my medical training at Western University in Morgantown, did internal medicine then at the University of New Mexico, then did dermatology at Penn State University and did a fellowship in Mohs surgery and skin cancer with Mary Maloney at Penn State University. I then was at Western Montana Clinic in Missoula for 6 years right after training before moving to the right side of the state. And have been, hard to believe, it's been almost 10 years I've been here in Billings.
Well, that's great. That's quite a lot of training for your job, but I'm glad you think it's fun. That's great.
It's still fun.
It's still fun. That's good. Dr. Lund, tell us about your training.
Well, I started out at Texas A&M for medical school and did my training there and chose dermatology because I loved to see the skin disease. I love to see the disease present in various different ways, and just the fact that the patient can tell you a whole history, but you can look at it and you can, just by the way it looks, you can have a good idea or tell what it is. And I loved it was just very interesting to me. So we went that route and went to the Marshfield Clinic for our dermatology residency training. Graduated there in 2009 and went into practice actually as a general dermatologist first in Coeur d'Alene, Idaho. And I just felt a desire to get more training and subspecialize in treating patients with skin cancer. And that's why I did the fellowship in Mohs surgery. And I actually did that here in Montana at the Billings Clinic under Dr. Michael Wenzel. And he was my mentor, and graduated last year and have stayed on and continued working here. So,
well, excellent.
Great addition to have you in the department.
Well, it's nice to have both of you. I know Dr. Wenzel's still with our department, and he's doing Mohs surgery, but he's also taking some time off to enjoy his family and be away from Billings a bit. So we're very fortunate to have both of you at Billings Clinic, and I can't believe it's 10 years. Time flies when you're having fun, I guess. And Dr. Lund, it's nice to have you here as well. Tell us about your fellowship training in Mohs.
Well, with Dr. Wenzel, what we did is about every day, 5 days a week, we treated 5 to 6 patients with skin cancer, and it was predominantly a surgical practice. And we probably did over 1,000 Mohs surgeries during that year. It was actually around 1,200 was the exact number, and so it was a busy year, and we focused on treating patients with skin cancers predominantly on the head and neck and critically cosmetic areas like the nose, the eyelid, the ears, and after removing the cancer through a special technique, then we would turn our way towards reconstructing the defect that was then left. And I learned so much from him. He's a master at reconstruction, and it was just a pleasure to work with him. And at the same time, I had the opportunity to work with Dr. Jones and get his input, and he was also invaluable. It was just an outstanding year. Couldn't have asked for better training.
Wow,
here.
well, they kept you busy.
They
There was
did.
no time on the golf course for you. There was lots of
No,
work.
no golf
Lots, yeah,
last
that's
year.
the sunshine,
So.
yeah. Well, we'll talk, you know, let's just stay on the subject of Mohs for a minute, because it is such a unique subspecialty of dermatology, and we're so fortunate to have your skills in this community, in this region, because I know you serve people in our entire service area, which spreads down to Wyoming and the Dakotas and up into central Montana. Dr. Jones, I'll ask you to give us the abbreviated Mohs surgery. What is Mohs surgery?
Well, Mohs is called Mohs after Fred Mohs, who developed the technique in the late 30s, early 40s. And he originally was given subsets of patients that were felt to be incurable of their skin cancer. And because of his forward thinking and this new technique that he arrived at, he was able to cure these patients that were otherwise thought to be uncurable. And in a nutshell, Mohs surgery is the most precise method of treating many types of skin cancer. It is the most tissue conserving. We don't take any more skin than we absolutely have to. And it has the highest cure rate of any method available. The technique that we use today is not exactly what Fred Mohs developed. There was some modifications of the technique by Stegman and Tromovich, which were two surgeons at the University of California, San Francisco. They took Dr. Mohs' technique and modified it a little bit using the frozen section technique that we use basically today. But it is by far the most tissue conserving and has the highest cure rate of any method that we use to treat skin cancer.
That's fabulous. I know sometimes in our area, rural, a lot of people are outdoors lots, get a lot of sun, and people like my father, who was a rancher, spent a great deal of time from the time he was a boy out in the sun, riding his horse to and from school, and out riding his horse and swimming, and there was no such thing as sunscreen. I think he wore a brim on his hat, but later in life he had all these little precancerous spots and things that showed up, and for a while he'd just go and wasn't to either of you. He would go and just kind of get the, I think they just kind of take the
melon baller
peeler and take off little things or freeze it and so on, and then one day he did end up in Dr. Wenzel's office because it was more serious, and that whole process probably, you know, saved his life, not to mention his nose, because I know when you start whittling away, there's not a whole lot of meat there on your nose. You've got a lot of bones. So I know that process a little bit just from his experience. And,
well, your father's experience is very typical of the patients we see. We see a lot of ranchers, farmers, outdoor enthusiasts, and many of a great proportion of our patient population are Caucasians of Northern European extraction, blue eyes, you know, red hair, blonde hair, and those people are a real setup. And especially when they've gotten in their early years, like your father riding his horse, you know, when they're teenagers, they don't pay attention. They're immortal at this point, you know, and so that's when the major portion of your risk of getting a skin cancer comes from. That's when you're really doing damage to your skin. And it's really a message we try to drive home to the kids today, but with varying degrees of success.
Well, the other thing that disturbs me is when I see a little baby out in the sun and they're not properly protected. I mean, what happens when a baby gets a sunburn?
Oh, it's quite painful, and
Yeah.
and really protective clothing is the most effective way of preventing sunburn. And sunburns over time, multiple sunburns, you continue accumulating that damage into your skin, and later in life it's going to present problems with you. So you'll see my kids swimming, they all have their sun shirts on, and if they're not in the pool, a hat is common, and it's important to start young in protecting their skin.
Well, it needs to be a way of life.
Right, and you mentioned the sunscreen. That's only a part of this whole sun protection. You're talking about hats and long sleeves, very important. Many times patients will ask, you know, well, is 30 enough? It's like, well, 30 is what we recommend, but that's only a part of all the things you should be doing.
Right.
You know, seeking shade, wearing a big hat, long sleeves, being aware of sun reflecting off of snow or sand or water. When you're out on the lake, you need extra sunscreen applied every 2 or 3 hours. You know, so that sunscreen is only a small part of the whole sun protection package.
And I think people forget the reapplication part. They put it on before they go out. They go swimming. They go play golf. They sweat a lot, and they come home and they say, how did I get burned? I used my sunscreen. And the issue is reapplying every few hours because it does not last all day, especially when you're active.
Well, give us the guidelines. What is the SPF that we should use?
Well, at least a 30.
Okay.
It should be UVA and UVB, gives you a broad spectrum of ultraviolet protection. And it should be water resistant or waterproof.
Okay.
And it should be applied before you go out, not after you've already started to burn. So 15 minutes before you go out, and then reapply it every 2 or 3 hours, or after sweating or after toweling, after you've gotten out of the water.
Sure.
So if you can do those things, you're several steps down the road toward the right path. But at least a 30, UVA, UVB, waterproof and water resistant.
I know visors and hats have to have a big enough brim to actually protect you. Sometimes little visors and little hats and baseball hats don't necessarily cover the ears. So wide brim hat.
At least 4-inch brim is recommended.
4-inch brim. And then I know now there's some great clothes. They're a little bit expensive, but they probably save your skin. The UV protection that you can wear golfing and out in the sun or fishing that allows some breathing but yet protects the skin. Long sleeves, I know you recommend that. What about time of day? Is there a time to stay out of the sun versus a time that it's less damaging to be in the sun?
You know, the peak hours are usually between 10 and 4, but you know, you want to go out and have fun and enjoy the sun. We're not telling people to completely stay out, but just be smart about it when you do go out and protect yourself. But those peak hours, especially with young children, I just make sure they know when the sun's at the highest point, that's when you're most likely to get burned. So.
Yeah.
What do you have to say about tanning beds and, well, I guess tanning beds, that's the one way to get an artificial tan.
Yeah. Do you want to? Yeah. Don't do it.
Don't do it.
We've seen a significant increase in melanoma, which is a very dangerous type of skin cancer, predominantly in young women between the ages of 19 and 35. And if you trace back, one of the things that's been more of a, what's the right word, more of a habit that's occurring is tanning. And indoor tanning, and our studies now show that there's a definitive increased risk of developing melanoma when you do tan. And so indoor tanning is dangerous.
Well, tanning beds have been around a long time. And people, I remember my folks 100 years ago, well, maybe not quite 100, but they were like, we're going to get a little tan before we go to Hawaii so we don't scare the people when we take our Montana, clothes off.
Well, there's no real safe dose of radiation.
No.
And that's basically what we're talking about. Whether you get radiation from the bulbs at the tanning bed or radiation from the sun.
Okay.
And it's ultraviolet radiation. And so it wouldn't surprise you that I told you it took 20 years to get thyroid cancer if you were next to Chernobyl, form of radiation. Well, it may take you 20 years to get your skin cancer if you're next to the radiation in the tanning bed or from the sun.
Okay.
And so, if you want to willingly expose yourself to radiation, we'll see you later.
Yeah. Well, I know. And I don't know what the, I guess it's just our culture that having a tan is something that's desirable.
Yeah.
And so even for men and women, alike, that having a tan promotes attractiveness, and so sometimes people want to have that.
Well,
what do you have to say? Oh, go ahead.
Well, I was going to say the one thing you can do is get a spray-on tan.
Okay, I was going to ask you about that. What about a spray-on tan?
Tan in a can.
Okay.
We like it. So that does give you the nice little tan that you want to get for the prom or the wedding or your vacation. But the one thing you have to be careful is you're not any less likely to burn later on. So if you get the spray-on tan, going to Hawaii next week,
don't think you've got
you still need the sunscreen.
Okay, that's a good point. Just because you look like you're kind of built up a little bit, you still
No,
you could really
but they're
burn under
perfectly
that.
safe. And so I encourage people, if they really want that glow, to go get the spray-on tan.
So either the spray tan, and even what about the Jergens
They're
and other
fine.
rub-on?
They're
That's
fine.
That's
The spray tans probably give you a little better appearance, but the lotions are fine too.
Okay. Well, I'm glad we talked about that because I know it's sort of your battle cry. It's your mantra that you have to help people protect their skin because it can be life-saving. Talk about what happens when skin cancer is not treated and goes wrong. And I know you mentioned melanoma can be fatal. What are the other kinds of cancer, and what should people look for?
The most common for non-melanoma skin cancers, which are mostly the basal cell carcinomas and the squamous cell carcinomas, the most common bit of history that we'll get from the patient is say, Doc, I've got this spot that won't heal. It's on my face. It's like, when was that? Well, that was 3 years ago.
Yeah.
You know, so any spot that spontaneously bleeds or won't heal over a period of 2 or 3 weeks, that's a spot of suspect.
Okay.
And so that's usually the basal cell carcinomas and the squamous cell carcinomas, which make up the vast majority of the skin cancers that we treat. The melanoma, as Jared mentioned, fortunately is less common, but more serious. And what is the most common bit of history you get from patients with melanoma?
Usually, it's a new mole or a changing mole is the most common. So if a patient comes in and says, you know, I've had this mole all my life, and over the last 6 months, it has changed dramatically. That would be a red flag to me. Or if a patient's in their 30s or 40s and says, you know what, this popped up all of a sudden out of nowhere on my back or on my leg, and that would be a red flag. And then, of course, there are specific small little details that we look at when we're evaluating the mole that would make us suspicious for melanoma. But a new or changing mole should be a red flag to a patient to have it addressed. Especially after that. Yeah.
Okay. Now, people can develop skin cancer anywhere on their body, can't they? I've heard somebody had it on their leg. You can get skin cancer anywhere, right?
For women, the most common location for melanoma is actually on the legs.
Okay.
For men, it's usually the upper back. But for the non-melanoma skin cancers, those are usually in areas that are chronically exposed to the sun. Your face, upper back, lower legs. We see a fair number of squamous cell carcinomas on the lower legs of women.
Okay. So you
But to answer your question, most of them are in sun-exposed areas. You can get them anywhere.
Okay. So as far as paying attention to your moles and looking at your skin, I've heard of, you know, that you promote regular skin exams, skin checks, that you go to your doctor and have them look over your body carefully.
Yeah, especially if you have a history of skin cancer, you've already had one, it's very important for you to see someone who's qualified to look at your skin with a critical eye, usually your board-certified dermatologist. Look at your skin once a year to make sure that there are some, not some subtle lesions that you as a patient are missing.
Right.
Of the patients who have a history of melanoma, about 10% of those patients will go on to develop a second melanoma, unrelated to the first. Half of those will be found by their physician, half of those will be found by the patient.
Okay.
About 1 in 5 Americans today will develop a skin cancer over the period of their life.
Okay.
And so moles that itch, moles that change, moles that bleed, new moles, spots on your face that won't heal, spots that spontaneously bleed, get those checked out.
So all those things are important. I've heard of mole mapping. Do you do mole mapping?
Dr. Sam Reck in our department has for the past probably year and a half begun mole mapping, which is serial digital photography of people's moles. He will take pictures of you if you meet the pretty strict criteria that for this procedure, but take digital photography and then be able to compare one visit to the next, say, well, this mole in your lower back has changed. You know, we need to take a sample of that. But Dr. Reck does that, been doing it for a year and a half or so, and he's had very good success with it.
So if people have never had a good, thorough dermatologist exam of their skin, it's probably good to have one at some point in their life, probably sooner than later, and just keep an eye on things and know if the mole changes, you know?
Absolutely, and especially if there's a family history of melanoma. If you can talk with your parents, your brothers and sisters, and you find out that someone's had a melanoma, you're a first-degree relative of that person, you should get a full skin exam by a board-certified dermatologist, as Dr. Jones suggested.
If someone you determine that they have a cancer, can they come right to you for care, or do they need to be referred by a dermatologist or a primary care physician?
You don't know. Easy answer to that is you don't need a referral.
Okay.
For Mohs surgery, if you have a biopsy-proven skin cancer, you can ask your primary, whoever did the biopsy, that you'd like to see one of us to treatment, and be happy to to see that, do a consult, talk to you about the procedure that we might want to go through. And Mohs is not the only way of treating skin cancer. If it is not indicated, you know, we might recommend something else.
Okay.
But if you have a suspicious spot on your face or back or whatever, you don't need a referral to see one of our general dermatologists. We have walk-in clinics twice a week.
That's fabulous.
Which, you know, you can come in, sign up, and be seen that day. But if your schedule permits, we also have readily available scheduled appointments.
That's great.
And so you don't need a referral, you can come right in.
That's wonderful. Let's go back to Mohs a little bit and talk about how, I know people come and they have to stay for a little while because you do some interesting things once you take that little specimen off. Talk about maybe the day in the life of a Mohs patient.
Oh, you bet.
How does that work?
Well, for example, today I worked on a patient who had a skin cancer right up here on the side of their nose. We started off by seeing where the cancer was and taking a small piece of normal tissue and taking that into our lab while the patient waits for about 30 to 45 minutes. We do it all under local anesthesia.
Is the lab in your department?
The lab is in our department, and within about 30, 45 minutes, we've processed the tissue in a way that we can look at 100% of the margin and see if there's any roots going downward or outward of the cancer. And so that way, if we identify a root underneath the microscope, we know exactly where it correlates on their skin, and we know exactly where to go back and take more. So it's not going back blindly and just taking a big hunk. We know exactly where to take a little more. And once again, we repeat it, take a small little piece, go through the lab again, and if we've gotten it all, we're done, and we turn towards the reconstruction aspect. If it's still traveling, we continue doing the process until the cancer's gone.
So you keep little teeny slices by little slices. And then you mentioned something about freezing. What is that?
That's how the tissue is processed
Oh,
in
okay.
our lab.
So it's frozen and you just look at it and you can see what's going on there. When you, so you take it down to where you finally have gotten rid of the roots and the whole piece, then what is reconstruction?
Reconstruction is looking at the defect and deciding which way the patient, which way to, in a sense, sew up the defect to give the patient the optimal outcome cosmetically. Often we we'll just sew it primarily together side to side. Sometimes we use a full thickness skin graft, and sometimes we'll even do a flap where we move tissue from adjacent to that area into the hole itself. And so many different ways to reconstruct, but also surprisingly we can often let these heal in on their own without doing much reconstruction, and they do wonderful. And so that just depends on the patient's tissue, how it moves, and how we feel the best way is to reconstruct the defect.
Where might you take skin from if you had to get more tissues to fill a spot?
Go ahead.
No, I was going to say, well, that's a very common question. The patients I say, well, take some right here. I need that little extra. I think, well, that one hasn't been exposed to the sun.
So you have to have
So we try to match for color and texture. So depending on where we're putting it, obviously if it's on the edge of the eyelid, it's going to be different than if it's on the side of the nose.
Sure.
But upper eyelids, around the ear, on the neck, sometimes collarbone, skin. But it depends on where we're putting it to. That's going to make a big difference where we harvest it from.
Well, you do masterful work, because I've seen people that have had Mohs surgery and you would never know that they've had it done because it heals so nicely. So I guess that's your mission, is to restore the natural look of the patient and to cure them of their cancer. So that's great. Let's talk about other diseases of the skin that patients come to you for. I know from my past history with Dr. Wenzel and others that the skin is the largest organ of the body. So,
most important, too.
And most important. There you go. And you can see the diseases right under your very own eyes. I love that. So talk about some of the other things, common things that people come to you for, and maybe not so common things.
Well, in the general dermatology realm, you know, often dermatologists get associated with acne and eczema, and those are two of the biggies that general dermatologists see. And I'm often asked, when do you start treating acne? You know, because isn't it just a component of growing up?
Yeah.
Well, there's the easy way to say, well, when it's causing a scar, And there are two different kinds of scars. The scars that you can see on the skin and the psychological scars that occur. Yes. And people sometimes forget about the latter because they can make a huge difference in the adolescent's self-esteem, their self-perception, how they interact with their peers, and that's often overlooked. And so we try to intervene before any scars have occurred.
Great. I like that.
Yeah. So and eczema is another common one, especially in the younger age group, in that 4 to 5, 6 toddler group. We have two dermatologists that really specialize in that pediatric group. Dr. Sam Reck was a pediatrician before he became a dermatologist, and Dr. Gail Clayman also has had vast experience and interest in pediatric dermatology. They've been both fantastic components of our department. I don't want to suggest that all they treat is acne and eczema.
No, I know.
But that's a big part of what we do as general dermatologists, what they do as pediatric dermatologists.
Well, I know that those are very common, particularly acne. Has there been any new developments in treatment for acne as far as medication or other therapies? Or is it kind of...
You know, the treatment's been pretty consistent, at least during my training.
Okay.
I haven't seen any groundbreaking developments.
No, not so much. You know, the one thing you read a lot about is Accutane. Sometimes it gets some what I consider to be bad press. Accutane is a great drug. It does have some side effects. It does have very specific indications. But as long as those indications are met and side effects are watched for, it's a fantastic drug. And I hope it doesn't go away. I mean, there's been some move to try to take it off the market, and I think it would be a real harm to our patients if that were to happen.
It's great to have that cure. I know somebody that went through that treatment, and they're pretty much acne-free for the rest of their life. It's just done it.
Right.
Well, it's really interesting to hear about this. I know you do nails, if they're fungus and weird things. Your nails are part of your skin too, is that right?
Yep.
We dermatologists tend to treat the hair, skin, and nails.
Hair, skin, and nails, that's right.
The hair, skin, and nails is good.
Is there a new pill for hair growth? Every time I hear something
Dr. Jones is taking it.
Right. It doesn't work very well.
Well, we'll wait for that for our next show. See how that's working for you. Well, we're running short of time. I thank you so much for coming and visiting with us about Mohs surgery, about dermatology, and anyone can make an appointment with dermatology by calling our appointment desk, 238-2501, or find out when the walk-in days are. Do you know those offhand?
Usually Tuesday and Thursday afternoons.
Tuesday and Thursday afternoon, you walk up to dermatology, second floor of the clinic, and put your name in, and you will be seen shortly after that. They take people in order of coming in and let you know about how long you have to wait. Tuesday and Thursday afternoon, so that's great. Thank you both very much. I learned a lot.
Always wear your hat.
Always wear your hat. Okay.
Appreciate it, Leslie.
Thank you.
Thank you, Leslie.